Our next speaker is Dr. Audrey Rostov, and she'll be talking on managing complications in DMEK or DSEK. Over to you, ma'am.
Thank you so much. It's a pleasure to be here. It's exciting to see so many friends again. And if I could have my slides, please, that would be helpful. Thank you. I'm going to be discussing managing complications in DMEK and DSEK. My financial disclosures, none are relevant. I'm going to concentrate on these three different scenarios: DMEK or DSEK after PK, DMEK insertion issues, and intraoperative hemorrhage. In general, I tend to do DMEK when there's a good view. It's my go-to for previous PKs, phakic patients or failed DSEK with minimal comorbidities, and DSEK for those more complex cases. When you are doing an EK, whether that's DMEK or DSEK following PK, you want to be sure about your graft sizing. I usually undersize about 1 millimeter, and so if you had a previous PK that was 8 millimeters, consider a 7 millimeter DMEK or DSEK. Also, you want to be aware of PAS. If you do have synechia, you may need to do a DSEK with a custom shape, like I learned from Dr. Praveen Vadavali, where you cut off an edge, sort of like a letter D. Keep in mind, larger grafts can be more difficult to unfold. For desmetarexis, when you have DMEK after a PK, you do have to strip endothelium. You do not with DSEK, although I tend to do that for both. And you want to be careful because you have to avoid the graft-host interface. When you are doing a DSEK following a PK in the scenario where you have aphakia or aniridia, I like to use a stay suture. And this is suturing the donor lenticle to the previous PK graft. You could see here that in this scenario, I was really happy that I did that, because that is the only thing keeping this donor lenticle from falling to the back of the eye and the retina. You could see that there on the OCT below. I was able to go ahead and rebubble this graft successfully. It's hard to do air bubble management in these cases. This is another trick you can use. This is what I call a safety suture. Whether you're doing a suture pull-through technique in the face of either aniridia or very little iris. This is someone I did a scleral fixated lens and a DSEK. They had a failed graft. They also had a tube. And so it's an older video, but you could see here what I'm about to do is place that suture there so that just in case the DSEK lenticle is going somewhere I don't want it to, and here's a push-in technique. You can also do a pull-through technique. I have that as a safety suture. This is the same patient post-operatively, about a month post-op, and that's the upper photo. There is an increased risk of graft failure with DMEK or DSEK with a history of glaucoma drainage devices, and so to keep that in mind, I know that Dr. Aldalvi is going to be speaking about that. When you have a previous PK, you need to be careful with your air bubble management because there is potential for rupture of the PK wound. You want to inject slowly. I like to use a 1 cc syringe. Here is a scenario where I did not, in fact, follow my own instructions. I aggressively injected, and that is the rupture of the PK wound. You think you're almost done, and now you have to sew up a good portion of the PK. Another tip when you're doing DMEK insertion, do not insert a DMEK graft into an overpressurized eye. If there is resistance on insertion, do not force it. Again, I did not heed my own advice right here, and I'm pushing and I feel resistance, and I still feel resistance. And what happens? There we go. Yeah, that's kind of a bad day when that happens, so you want to avoid that. I promise I also do successful DMEKs as well. I wonder why they always ask me to talk about complications. Perhaps it's a hint. So again, what happens if you have pressure on DMEK insertion, but you did not see the graft coming outside of the eye? Well, you've got to look for it. And this is actually what happened. I didn't know where the DMEK graft was, and so I'm using a little Kugelin hook, a push-pull, and I'm looking through the pupil, and it wasn't there. And so here, this is actually, it was a YouTube song that went I still haven't found what I'm looking for. This is a reenactment of actually what we did. We took the fluid out of the drape pocket and put it into sterile bowls, and that's how we eventually found the DMEK graft. We still didn't see it, but then we added trypan blue to the little bowls and then figured out where it was. What happens in this case, some of you have seen this video. I still get nightmares from it. In fact, it makes you feel a little sick. You might be sorry you had a large breakfast. I'm about to insert the DMEK graft, and oh my goodness, what happens here? Yeah, it's like a scary movie. I'm pretty sure I have hit the aorta at this point in time, and I have to irrigate out. So the first thing you want to do is save the graft, right? You want to make sure that the graft is safe, so you're saving the graft, irrigate out, figure out where that's coming from. It can either be coming from the PI, it could be coming from the wound. In my case, it was coming from the wound, and I finally figure out where this is coming from. And yeah, the eye fills with blood once again. You think you're home free and you're not. Eventually, I did locate the site of the bleed and then got it under control with some tamponade, and I was able to successfully, in fact, insert the graft and unfold it. Management of intraoperative hemorrhage. Number one, do not panic, take your own pulse, establish the source, maintain the safety of the graft, and then tamponade with whatever you have, air, viscoelastic, epinephrine, adrenaline, BSS, whatever you think will work at the time. In summary, with EK after PK, you want to size the graft smaller than the PK in either a DMEK or a DSEK. Remember about safety and stay sutures, both as good tricks. Inject air slowly so you don't do what I did. Do not insert into an overpressurized eye with DMEK insertion. Obviously avoid the pupil. Thank you so much. It's a pleasure to be here.
Any questions?
Audrey, let me ask a quick question then. What is your thoughts on, to avoid bleeding from the PI, a lot of people say, especially in the Fuchs cases, maybe doing PI preoperatively with the laser so you avoid the issues when you're doing intraoperative. And the second thing I was going to ask was, there's some sort of discussion about maybe trying to give some fibrinolytic to basically get rid of fibrin, because even though you get rid of blood, of course you're going to get more aqueous fibrin release as well, which obviously is very difficult to get rid of. And with an endo-out technique, you've always got the chance of it sticking like glue to the fibrin area. Do you know what I mean?
Yeah, actually, both are good points. One thing I've taken to doing is I've taken to stopping blood thinners. That patient was on Eliquis, and so I never used to stop blood thinners, and now I actually do for DMEK and DSEK a couple days ahead of time. Certainly, fibrinolytic is a good idea if you have access to that. I think that that's an excellent concept as well. Yeah, both are very good ideas.
Will you do DMEK in aphakic eye?
Sorry?
Will you do DMEK in aphakic eyes?
In aphakic eyes? I don't, because I like life to be easier, and so if it's in an aphakic, well, actually, if it's an aphakic eye with an iris, which is not usually the case, then yes. But if it's an aphakic eye without an iris or a very little iris, then why make life more complicated is my philosophy. I have enough complications as well, so as you can see.
What about the rebubbling rates in post-PK eyes for DSEK and DMEK?
Sorry, what's?
Rebubbling.
Oh, rebubbling rate, sorry. The rebubbling rate is actually maybe a little bit higher in DMEK after PK, but not terribly so, as long as there's no other confounding factors such as glaucoma or a glaucoma drainage device. I used to do DMEK on everything, right? And now with glaucoma, I've tended to be more picky. If there's a glaucoma drainage device, like a tube, for example, then I tend to just do a DSEK because I know it's going to fail earlier anyway, usually.
Thank you.
Yeah.
Yeah.
Thank you.
Thank you. I think in India, most surgeons prepare their tissue themselves. So we get enough time to tamponade the anterior chamber. Once we do a PI, we inject the air bubble and that maintains the pressure for that particular time. In the meantime, you shift to prepare your DMEK or a DSEK tissue, and that gives enough time for oozing to stop, and you have a nice controlled uninflamed and blood cells in the anterior chamber.
Yeah, I do the PI at the time of surgery. I know people who do it ahead of time. Most of the time, I do not have an issue with it. Of course, there's always that potential, but most of
Especially
the
if
time
you
I
use a
don't.
vitrector for doing iridotomy, that's quite safe. Thank you.
Yeah, thank you.